back to me to present on clinical events following COVID-19. So this work that I'm going to share with you is more focused on COVID infection than vaccination. But given the rapid rollout of the COVID vaccines, it's impossible to study COVID infection without accounting for vaccination. This work was completed as part of the National Cause Study Programme. So our team at Bristol was funded through the Longitudinal Health and Wellbeing Study, one of 4 or 6 national course studies led by, our particular study was led by Nish Chaturvedi at UCL and Jonathan Stern at Bristol. And the aim of that study was to understand the long-term impacts of COVID-19 on mental, physical, and economics. And we set out to look at several events and whether they were elevated post-COVID. And this was part of defining long COVID. Back when we started this work, there was no clear definition of long COVID, and it was felt that if we could look at what was elevated post-COVID, that might help us to do that. So the aims of this work were to examine the associations of diagnosed COVID-19 with subsequent clinical events. And we did this prior to vaccine availability in a group of vaccinated individuals and a group of unvaccinated individuals. And then where possible, because we had large data, we were able to start digging into some subgroups. So we wanted to examine associations of diagnosed COVID with subsequent clinical events, in particular groups by COVID-19 severity, age, sex, ethnicity, and prior history of the outcome. So as I alluded to, we can't study COVID infection without considering vaccination status. So we actually looked at 3 different cohorts of individuals. Our first cohort, and by far the largest, is the pre-vaccination cohort. That consists of essentially all adults available in open safely TPP. And we followed these individuals from the start of the pandemic, which we defined as the 1st of December 2020, through to the 14th of December 2021, when the Omicron variant became the dominant type. Because of the time that these individuals were exposed to their COVID infection, they likely had the wild type or alpha variants. And because they were exposed prior to vaccines available, they were unvaccinated at the point that they had their infection. We then looked at the vaccinated cohort. The majority of adults in the UK did indeed get vaccinated. This consisted of 14 million individuals, and we followed these individuals in the Delta era, so from the 1st of June 2021 through to the 14th of December 2021. And then the complement to the vaccinated cohort is the unvaccinated cohort. So this is the remaining just over 3 million individuals, and again, we followed them in the Delta era of the pandemic. For those of you that missed seeing this graph on the news of all the COVID cases, this is what it looked like in terms of how our cohorts are defined. So the pre-vaccination cohort starts right on the left-hand side of this graph, running through to the last 6 months where all the vaccinated and the unvaccinated cohorts are. We looked at a large range of outcomes, which are listed on this slide. Some of these projects are ongoing, but today I will focus on cardiovascular, mental health, and diabetes, and these are the 3 published papers that have come out of this work. Okay, I am a statistician by training, so my favorite slide, but not the prettiest. This was a time to first event analysis, so we used Cox models with a calendar time scale, and this was important to account for the differences that we saw in the pandemic. So going back to that graph that I showed you with all the different amounts of COVID at different times in the pandemic. It was also really important to stratify by region because different areas of the country had different levels of COVID at different times. We're reporting adjusted hazard ratios for follow-up after versus before or without COVID-19, and we split them into critical periods that we thought were important. So that first 4 weeks is usually very important, and then the time after that is split into larger chunks. We are blessed with Open Safely to have access to a lot of data, and it's not always necessary to analyse all of that data to answer the questions that we want to answer. So in the data, we have a group of people who will have experienced our outcome, a group of people who will have experienced our exposure. A subset of those will have experienced both the exposure and the outcome. There's also a large proportion of people that experience neither the exposure or the outcome. And statistically, they are not contributing much to our analysis. So we can be parsimonious with our use of data, reduce our run times, be more green, and use a sampling approach. So we kept everyone who experienced the outcome, everyone who experienced the exposure, and then a 20% sample of the people that experienced neither the exposure or the outcome. And then we use inverse probability weighting to account for this sampling to get back up to results that reflect the whole population. A quick note on the patient characteristics between our different populations. These captured what we know about people in these various groups. So the pre-vaccination represented the broad population of Open Safely and the representativeness of Open Safely TPP. But the vaccinated and unvaccinated groups differed slightly. So people in the unvaccinated population are more likely to be male, they're more likely to be younger, they're more likely to be from non-white minority groups, and they're more likely to live in deprived areas. Okay, some results. So these plots show on the left-hand side arterial thrombotic events, which represents one of our cardiovascular outcomes. In the center, depression. And then on the far right-hand side, type 2 diabetes. And here you can see the results for the pre-vaccination cohort. And across all three different diseases here, we see an elevated risk initially after COVID, which attenuates over time, but never quite gets back down to 1. So they're still slightly elevated in the case of this pre-vaccination cohort up to 2 years after COVID infection. The next group is the vaccinated group. So these people differ by their vaccination status to the pre-vaccination group that we were just looking at. And you can see here that the events are elevated post-COVID, but not to the same extent as they were for the pre-vaccination cohort. And then our final cohort, the unvaccinated cohort, is most similar to our pre-vaccination cohort. So they are also unvaccinated at the point that they have their COVID infection. But actually for arterial thrombotic events and type 2 diabetes, these people actually have an even higher elevated risk of these events post-COVID. I mentioned the subgroups, so just to touch on those briefly, this graph separates by COVID severity. So on the top, we have people that were hospitalized with their COVID, and along the bottom, people who were non-hospitalized with their COVID. And you can see that the high rates of these events following COVID seems to be driven by severe COVID. The people that were hospitalized were far worse off than the people that were non-hospitalized. Also, a plot about prior history of events. So this is an analysis that was particularly interesting for the mental health work that we did. And here you can see on the left-hand side, people who had no prior mental health issues, people with mental health issues within 6 months, and people with mental health issues more than 6 months. Here you can see that people that had prior history of mental health issues were more likely to have further ongoing mental health issues after their COVID infection. Okay, so to summarize, as you might have expected, health is worse after COVID-19 infection, with more diagnoses of pretty much all the outcomes that we've studied so far. The incidence of these outcomes is highest initially, but then attenuates over time. But we are seeing these continued effects of COVID up to 6 months, and in some cases up to 2 years after infection. People who were vaccinated when they had their COVID had fewer outcomes, and people who were hospitalized with COVID were worse off. If you would like to read any more about any of these studies, they're published, happy to talk about them, and of course take questions on them in the Q&A. This isn't work that just myself or even Rachel did on us did it by ourselves. We have a huge team at Bristol. This is an outdated slide, so sorry to those of you who are here that aren't on here, but here are some of the people who are at Bristol and those who aren't on the train you can meet today. And finally, thank you all for listening.